Welcome to another episode from the Veterinary Research Channel. Today, we're diving deep into a crucial aspect of veterinary medicine, fluid therapy for our canine and feline patients. Fluid therapy is a very common treatment in veterinary medicine that can help a wide range of conditions. These guidelines aim to assist veterinary professionals in administering fluids safely and effectively to dogs and cats. Our story begins with the understanding that fluids are drugs. Just like any medication, they have the power to heal, but also the potential to harm if not used correctly. The key is to prescribe fluids thoughtfully, considering the individual needs of each patient to achieve the best results while minimizing risks. Imagine a veterinarian facing a dehydrated patient. The animal's body is like a landscape with different compartments, intracellular, interstitial, and intravascular, each requiring a specific amount of fluid to function properly. The veterinarian needs to assess each of these compartments and what fluids may be needed. A common mistake is to assume that one fluid rate fits all. Administering fluids at twice the maintenance rate might seem like a simple solution, but it can lead to trouble. For instance, a patient with interstitial dehydration would take far longer to rehydrate with this approach than the recommended 12 to 24 hours. Similarly, in cases of acute kidney injury, the fluid input rate should match the kidney's ability to handle fluid volumes. And when it comes to intoxications, high fluid rates might not accelerate toxin excretion and could even cause fluid overload. To prescribe effective fluid therapy, veterinarians need a solid understanding of the body's fluid compartments. The intracellular and extracellular fluid compartments contain 67% and 33% of total body water, respectively. It's like knowing the map of the body's hydration system. Before starting fluid therapy, a veterinarian must assess the patient, starting with the intravascular fluid space. This involves checking the patient's history and perfusion parameters like mentation, heart rate, and capillary refill time. Then, they evaluate the interstitial fluid space for dehydration. The fluid administered should be a buffered isotonic crystalloid with a sodium concentration similar to the patient's. In some cases, a hypertonic crystalloid or a colloid solution might be necessary for rapid intravascular volume replacement. Throughout the process, close monitoring is essential until fluid homeostasis is achieved and maintained. Now, let's talk about the practical aspects of fluid therapy. When creating a fluid therapy plan, veterinarians consider three main phases: resuscitation, rehydration, and maintenance. The chosen administration route depends on the severity of the patient's fluid deficit and their ability to take fluids orally. Whenever possible, the enteral route, which includes oral administration, should be favored. Hypovolemia and dehydration are common conditions that require fluid replenishment. Hypovolemia is when there is decreased volume within the vascular space. Dehydration is when the body loses more fluids than it takes in, resulting in an imbalance of water and electrolytes. Untreated hypovolemia can lead to serious complications, so immediate medical attention is crucial. To treat hypovolemia, veterinarians administer a buffered isotonic fluid bolus intravenously. For cats, the dose is 5 to 10 milliliters per kilogram, while for dogs, it's 15 to 20 milliliters per kilogram, given over 15 to 30 minutes. These boluses can be repeated if the patient remains hypovolemic. Dehydration can be managed by replenishing lost fluids through oral rehydration or subcutaneous administration. The key is to monitor the patient closely and adjust the fluid prescription as needed. Selecting the right intravenous fluid involves considering factors like the patient's age, underlying medical conditions, and electrolyte balance. A patient's sodium concentration must always be considered. Fluid prescriptions should have concrete endpoints to monitor to ensure hypovolemia and dehydration are resolved. The choice of fluid administration route depends on the severity of the fluid deficit. Hypovolemia always requires intravenous or intraosseous fluid delivery. Dehydration, on the other hand, can be corrected through intravenous, subcutaneous, or enteral fluid administration, or a combination of these routes. Intravenous and intraosseous routes are preferred for patients with severe fluid deficits, acute fluid losses, and perfusion deficits. These routes allow for rapid dispersion of fluid and electrolytes. Subcutaneous fluid administration is a practical option for long-term hydration support, especially at home. However, it's essential to avoid prescribing subcutaneous fluids for euhydrated patients, as it may be harmful in those with challenges in body fluid homeostasis. Enteral administration, whenever possible, is a great option. Delivering fluids and diets through voluntary intake or feeding tubes can be particularly useful in dehydrated patients who cannot tolerate intravenous fluids. Now, let's shift our focus to fluid therapy during anesthesia. Fluid therapy is often recommended to counteract the vasodilation and decreased cardiac output induced by inhaled anesthetics. The recommended fluid administration rate during anesthesia is 5 milliliters per kilogram per hour in dogs and 3 to 5 milliliters per kilogram per hour in cats. The goals of fluid therapy in anesthetized patients include correcting potential fluid deficits, maintaining catheter patency, and supporting cardiovascular function. However, it's important to prioritize the correction of hypovolemia and dehydration before general anesthesia whenever possible. Hypotension is a common complication during anesthesia. In such cases, start by adjusting vaporizer settings and administering crystalloid fluids. If hypotension persists, consider sympathomimetic drug therapy or colloid fluid therapy. Monitoring is crucial during anesthesia. Signs of fluid overload include a gallop sound or new murmur, edematous tissues, clear nasal discharge, pulmonary crackles, and low oxygen saturation. Patients with renal disease require special attention. It's crucial to correct dehydration before anesthesia, optimize cardiac output, and closely monitor blood pressure. Avoid attempting to rectify hypotension by using excessive fluid infusion rates. When it comes to ill patients, remember that enteral routes of fluid delivery are very important. Do not withhold fluids in patients who are dehydrated or hypovolemic because of concurrent anemia. And always mitigate electrolyte derangements carefully. Sick patients often present complex challenges in fluid therapy. Nutritional therapy is one of the most neglected patient requirements during hospitalization. After 72 hours of anorexia, a patient's metabolism shifts to alternate energy sources. Nasoesophageal, nasogastric, or esophageal feeding tubes facilitate caloric intake, and water can be mixed with food or administered separately. Anemia is another common issue in sick patients. Do not withhold fluids in anemic patients. If an anemic patient is also dehydrated or hypovolemic, provide fluid therapy while recognizing that they may require blood products. In patients with kidney failure, fluid therapy can be challenging. Assess dehydration by evaluating skin turgor over the rib cage, analyzing weight trends and sodium concentrations, and identifying signs of fluid overload. Patients with hypovolemia and edema also require careful management. The underlying cause of the edema must be considered in order to safely provide fluids. For patients with traumatic brain injury, the primary fluid therapy goal is optimizing cerebral perfusion pressure and mean arterial blood pressure. Osmotherapy, using osmotic agents like hypertonic saline or mannitol, is common in treating these patients. Electrolyte imbalances are common in ill patients. Hypokalemia, or low potassium, can be treated with potassium chloride supplementation in intravenous fluids. Sodium imbalances, such as hyponatremia and hypernatremia, should be managed with care to prevent potentially life-threatening fluid shifts in the brain. Vasodilatory shock requires a multifaceted approach. Rapid administration of fluids, broad-spectrum antibiotics, source control, and pharmacologic interventions are all important. Hypothermia and hypoglycemia are other considerations in ill patients. Warming intravenous fluids can help mitigate hypothermia. Dextrose should be administered to patients exhibiting clinical signs related to hypoglycemia. Fluid overload, or fluid intolerance, is a clinical spectrum that can range from hypervolemia to life-threatening edema. All patients receiving fluid therapy are susceptible to fluid intolerance. To reduce the risk of fluid overload, use a low-volume strategy for fluid resuscitation, tailor ongoing fluid therapy to meet each patient's needs, and include all fluids delivered as medications, infusions, flushes, and enteral feedings in fluid balance calculations. Weigh patients frequently and regularly document fluid inputs and outputs to help identify positive fluid balance. Many questions and controversies surround fluid therapy in veterinary medicine. For example, the safety of synthetic colloids is a topic of debate. While colloids rapidly expand the intravascular space, concerns have been raised that extravasation of these synthetic macromolecules increases tissue edema and reduces oxygen delivery. Another question is whether plasma can be used to address hypoalbuminemia. While natural colloids like albumin and plasma are preferred over synthetic colloids, the volume requirement and cost of plasma can be limiting factors. The use of potassium-containing balanced isotonic crystalloids in hyperkalemic patients is also debated. However, studies have shown that these fluids are not detrimental for fluid resuscitation and rehydration in hyperkalemic cats with urethral obstruction. Finally, the use of intravenous fluids during cardiopulmonary resuscitation is a topic of discussion. Fluid therapy is indicated during cardiopulmonary resuscitation if it will help mitigate hypovolemia that led to the arrest. In conclusion, fluid administration is a cornerstone of therapy for many canine and feline patients. A personalized fluid therapy plan is needed to ensure the proper fluid is administered at the appropriate rate and volume. Relying on a one-rate-fits-most-patients strategy is not only impractical, but also potentially harmful. Thank you for listening to the Veterinary Research Channel. A link for the referenced paper is in the video description. Remember to test your knowledge by answering the questions in the description, and as always, keep those minds inspired, hearts light, and tails wagging.